Good day to our dear participants or dear audience. I am Donis Bendicio, psychologist from Lahok Training Center, and I'm pleased to welcome you to this exclusive recording of webinar for our subscribers on treatment planning of obsessive-compulsive disorder using ERP, an introduction. So this webinar or learning session offers participants an overview of how exposure and response prevention or ERP, the gold standard approach for OCD, can be effectively integrated into treatment planning. It will highlight the core principles of ERP, practical steps in structuring sessions, and strategies for addressing common challenges in implementation, designed for mental health practitioners, students, and those interested in evidence based interventions. The session aims to build foundational knowledge for supports both clinical practice and a deeper understanding of OCD management. According to the DSM-5, obsessive-compulsive disorder or OCD is characterized by the presence of obsessions, which includes recurrent, intrusive, and unwanted thoughts, urges, or images that cause marked anxiety or distress, and or compulsions, which includes repetitive behaviors or mental health or mental acts performed to reduce distress or prevent a feared event, which are time consuming, taking more than 1 hour per day, or cause significant impairment in social, occupational, or other important areas of functioning. The ICD 11 similarly defines OCD as the presence of obsessions and compulsions that are recognized by that individual as excessive or unreasonable. They are time consuming and interfere with daily life, distinguishing it from the anxiety and stress related disorders. Both classifications emphasize that symptoms are not attributable to physiological effects of substances, medical conditions, or better explained by another mental disorder. In obsessive compulsive disorder, OCD, obsessions are unwanted, intrusive, and persistent thoughts. These are images or urges that cause significant anxiety or distress, such as fears of contamination, harm, or moral transgression. In contrast, compulsions are repetitive behaviors or mental acts like excessive hand washing, checking, counting, or silently repeating words, performed in response to these obsessions, usually to reduce distress or prevent a feared outcome. While obsessions arise internally and feel uncontrollable, compulsions are the outward or mental actions that individual feels driven to perform even if they recognize the behavior as excessive or irrational. OCD can present in different subtypes depending on the themes of obsessions and the compulsions used to manage them. One common subtype is contamination and cleaning, where individuals have intense fears of germs, dirt, or illness. To relieve the distress, they may engage in compulsive washing, sanitizing, or avoiding situations perceived as dirty. For example, a person might wash their hands dozens of times a day until the skin becomes raw or avoid touching doorknobs for fear of contamination. Another subtype is checking and doubt, where individuals fear harm will occur if they do not repeatedly check or verify certain things. They may compulsively check whether doors are locked, appliances are turned off, or that no harm has come to others. For example, someone might spend hours ensuring the stove is off or driving back to a location to confirm they did not cause an accident. This subtype often stems from an overwhelming sense of responsibility or fear of making catastrophic mistake. A third group of subtypes involves symmetry, order, and intrusive thoughts. People with symmetry and ordering obsessions feel an intense need for things to be just right and may spend excessive time arranging objects symmetrically or performing tasks in a specific order. Intrusive thoughts, on the other hand, involve distressing taboo or aggressive mental images, such as fears of shouting obscenities in public or harming a loved one, which the person tries to neutralize with mental rituals like counting or praying. These subtypes highlight the wide range of ways OCD can manifest, often blending across categories in a single individual. Although obsessive compulsive disorder and OCD or obsessive compulsive personality disorder or OCPD sound similar, they are distinct to one another. OCD is an anxiety disorder characterized by intrusive unwanted obsessions, disturbing thoughts, images, or urges, and compulsions, repetitive behaviors, or mental acts performed to reduce the stress, prevent feared outcomes. For example, someone with OCD may wash their hands repeatedly to ease overwhelming fears of contamination. The symptoms are typically ego dystonic, meaning the person recognizes them as irrational or distressing but feels unable to control them. On the other hand, OCPD is a personality disorder marked by a pervasive pattern of perfectionism, orderliness, and control that interferes with flexibility and efficiency. People with OCPD tend to be preoccupied with rules, organization, and details, often at the expense of complexing tasks or maintaining relationships. Unlike OCD, the traits of OCPD are ego-syntonic, meaning individuals usually see their behaviors and attitudes as appropriate or even beneficial, even when others view them as rigid or controlling. For example, a person with OCPD may insist that a group project follow their exact method, believing their way is the only right way. The key difference lies in the nature and experience symptoms. OCD involves distressing obsessions and compulsion that individuals want to stop, while OCPD, while OCPD reflects ingrained personality traits that individuals believe are correct or necessary. OCPD may require long-term psychotherapy, particularly cognitive behavioral or schema-focused approaches to address maladaptive personality patterns. An obsession is a seen conditions like OCD, in an intrusive, unwanted thought, image, or urge that causes distress and leads to anxiety, reducing behaviors or mental rituals. Even though the person does not want these thoughts and often finds them irrational. In contrast, an addiction involves a compulsive drive to engage in a rewarding behavior such as substance use, gambling, or gaming. Despite negative consequences, where the person usually experiences cravings and desire and derives temporary pleasure or relief from the activity. The main difference is that obsessions are ego dystonic, unwanted, and distressing, while addictions are ego syntonic, initially desired and pleasurable through, although they are harmful over time. ERP, or the exposure response prevention, is most commonly applied to OCD, where individuals are gradually exposed to feared thoughts, images, or situations while being prevented from performing their usual compulsions. For example, a person with contamination fears may be asked to touch a doorknob without immediately washing their hands, and learning over time that anxiety decreases naturally without compulsion. Now, ERP helps break the cycle of obsession and compulsion by reducing avoidance and teaching the brain that the feared outcomes are less threatening than perceived. Beyond OCD, ERP has been adopted to treat anxiety disorders, particularly specific phobias and social anxiety disorder. In specific phobias, exposure involves gradual confrontation with a feared object or situation, such as spiders or heights, while response prevention focuses on reducing avoidance or safety behaviors. In social anxiety, ERP may target situations like initiating conversations or giving presentations, while preventing escape behaviors such as avoiding eye contact or rehearsing excessively. This approach help, helps clients build tolerance to discomfort and reduces the power of anxiety driven avoidance. ERP can also be applied to health anxiety and body focused repetitive behaviors like skin picking or hair pulling. In health anxiety, clients may be exposed to bodily sensations or feared medical information while being prevented from seeking reassurance through repeated doctor visits or online searching. For body focused behaviors, ERP may involve resisting the urge to pick or pull when exposed to triggering situations, paired with strategies to tolerate the urge. By extending ERP across disorders, clinicians harness the same principle. Exposure to feared cues while preventing maladaptive responses, ultimately retraining the brain's anxiety and reward systems. ERP typically follows a structured process to help individuals gradually face their fears and reduce compulsive behaviors. The first step is assessment and psychoeducation, where the therapist and client identify specific obsessions, compulsions, and avoidance patterns, while also explaining how OCD works and how ERP can reduce symptoms. The second step involves developing a fear hierarchy where your client ranks feared situations or triggers from least to most distressing, providing a roadmap for gradual exposure work. Now, the third step is gradual exposure, in which the client intentionally confronts feared thoughts, images, or situations from the hierarchy, starting with less distressing ones. So, this exposure is paired with the fourth step, which is response prevention, where the client resists performing their usual compulsions or safety behaviors. For example, someone with contamination fears may touch a surface they believe is dirty and then avoid washing their hands. Over repeated sessions, anxiety naturally decreases, teaching the brain that the feared outcomes are unlikely or tolerable. And so finally, the last step is processing and generalization. After each exposure, the therapist and client review what was learned, emphasizing the progress and correcting distorted beliefs. Now, the goal is the client to internalize these skills and apply across situations, not just in therapy sessions. Over time, the ERP empowers individuals to tolerate uncertainty and reduce reliance on compulsions and regain control over daily functioning. Providing a treatment plan for OCD, particularly one that integrates ERP or the exposure and response prevention, is important because it offers a structured, evidence based approach that helps break the cycle of obsessions and compulsions, while guiding both client and the therapist through measurable steps toward recovery. A clear plan ensures consistency, tracks progress, addresses individual needs, and prepares strategies for challenges or setbacks. And ultimately, increasing treatment effectiveness and empowering individuals to regain control over daily lives. Evidence-based care is important in treating OCD because it draws on therapies that have consistently show effectiveness, such as the ERP and CBT. Now, these approaches help individuals confront their intrusive thoughts, reduce compulsive behaviors, and even reframe unhelpful thinking patterns. In many cases, treatment may also include medication, such as serotonin 3 uptake inhibitors or SSRIs, which can reduce the intensity of symptoms and make it easier for clients to engage in therapy. By combining psychological and psychopharmacological strategies, when needed, care becomes more comprehensive and increases the likelihood of long term improvement. Now, the holistic perspective is equally important as recovery from OCD does not occur in isolation. Social support, family dynamics, and cultural context significantly shape how individuals experience symptoms and respond to treatment. For example, family members may unknowingly accommodate compulsions, or cultural beliefs may influence the form of sessions take. Addressing these broader factors helps reduce barriers, strengthen the resilience, and ensure that the treatment is both practical and culturally sensitive. Now, this holistic lens allows care to move beyond symptom reduction. Now, it builds that kind of improvement quality of life and overall well-being for that individual or the client. OCD is a mental health condition marked with the presence of intrusive unwanted thoughts, image or urges, and repetitive behaviors or mental acts performed to reduce the distress these obsessions create. Now, this experience is often overwhelming as individuals feel caught in a cycle that they cannot easily control, despite recognizing that their fears or rituals may be excessive. Now, these symptoms go beyond ordinary worries or habits, becoming time consuming and disruptive to everyday life. At the heart of OCD is the OCD cycle, which begins with an obsession, triggers anxiety or distress, and then it prompts the individual to perform a compulsion in an attempt to find a relief. While this compulsion temporarily reduces discomfort, it reinforces the obsession over time. So strengthening the disorder's grip. Now, this cycle can interfere the daily functioning, make it difficult to concentrate at school or work, and then maintaining healthy relationships or engage in routine activities without disruption. Left untreated, OCD can significantly diminish quality of life, which is highlighting the importance of recognizing its impact and seeking timely support, of course, with psychotherapy. Accurate assessment of OCD requires structured approaches that capture the severity, frequency, and impact of situations, or the symptoms rather. Structured interviews allow the clinician to gather detailed information on the nature of obsessions and compulsions. So their onset and the degree of impairment they cause, and this systematic method reduces bias and ensures that important diagnostic criteria are addressed. By standardizing the process, structured interviews also improve reliability across different clinicians and provide a clear foundations for treatment planning. In addition to interviews, clinicians often use rating scales such as the Yale-Brown Obsessive-Compulsive Scale or the Y box to measure symptom severity and track progress over time. Now, functional analysis further deepens understanding by examining the specific triggers, thoughts, the emotions, and behaviors that maintain that OCD cycle. For example, when identifying how contamination fear leads to hand washing rituals, they help to clarify the function of compulsions in reducing distress. So we combine structured interviews, validated rating scales, and functional analysis provides a comprehensive picture of the disorder, guiding the effective and personalized intervention. Selecting treatments for OCD requires tailoring approaches for which fit the individual's needs, the symptoms, the personal context. Now, the psychotherapy remains a first-line option with the ERP as the most effective evidence-based treatment. Now, ERP directly targets the OCD cycle by helping the clients face feared thoughts or situations without engaging compulsions. Other therapeutic options such as the CBT, the ACT, the acceptance commitment therapy, or the mindfulness-based strategies may also help in integrating, addressing the unhelpful thought patterns which acceptance of uncertainty and reduce overall distress. Now, these flexible approaches allow the therapy to be adapted to the client's readiness and values. Medication may also play an important role in terms of moderating the severe symptoms or addressing the struggle to fully engage in psychotherapy. SSRIs, no, and the other antidepressant medication or psychiatric medication can help to reduce intrusive thoughts and compulsive urges, making it easier for clients to benefit from ERP and other therapeutic strategies. Now, equally important is family involvement as loved ones often play their role in maintaining the reduction of the symptoms. The families may unintentionally accommodate rituals such as the providing different uh, reassurance or adjusting household routines to avoid triggers, which reinforces the disorder. By involving family members in treatment, they can learn to reduce the accommodation, set healthy boundaries, and provide supportive encouragement for ERP practice. Now, this collaborative approach not only strengthen the effectiveness of treatment, but also builds a more important supportive environment for long-term recovery. The vicious cycle of OCD begins with the intrusive thoughts as we know it, and then to manage this discomfort, the individual engages with the compulsion. The short-lived comfort reinforces that belief that compulsions are necessary, making obsessions stronger and more frequent over time. As the cycle repeats, the person becomes increasingly trapped in this cycle, with OCD consuming more energy, time, freedom, and ultimately impairing the functioning of that individual. In contrast, the cycle of OCD wherein we integrate these therapies, no, or approaches, we somehow lead to a more healthier response. So it emerges when individuals learn how to face their obsession without performing compulsions, or often through treatments like ERP. By resisting the individual rituals, or anxiety naturally decreases over time, which teaches the brain that perform outcomes are less threatening than imagined. So each success builds the confidence of an individual or the client in terms of building the resilience and reinforcing a more healthy or healthier coping strategy. So over time, the positive cycle replaces fear-driven behaviors with greater flexibility and control. So allowing individuals to reclaim their daily lives and move forward long-term well-being. A practical way to apply ERP is to start by identifying the triggers. So assigning the SUDs or the subjective units of distress scale to measure the level of discomfort they cause. And then we list triggers in order of lowest and the highest SUDs and begin with the least distressing one. We then choose one exposure from the list and then facing it, refraining from performing the compulsion, and staying with the anxiety until it decreases by about 50%. So practice this exposure daily, either through real life or in vivo or imaginary exercises until it no longer triggers significant anxiety. So once mastered, move on to the next item on the list. So gradually working your way up to the hierarchy toward greater tolerance and reduce reliance on compulsions. Effective OCD treatment can combine the ERP, the CBT, and other techniques where clients not only face their triggers without compulsion, but also learn to challenge distorted thoughts driven by their fears. Now, techniques like the cognitive bias modification target common OCD biases, such as misinterpreting harmless situations as dangerous or overestimating personal responsibility for preventing harm. Now, success requires being fully committed, reminding yourself that although the process is difficult, the long-term relief makes it worthwhile. So it's also important to watch for avoidance and escape behavior. So since these can subtly maintain the OCD cycle and reduce benefits of treatment. When working on OCD recovery, it is important to watch for the secondary gain, such as when the brain benefits from OCD by receiving extra help or attention from others, which can unintentionally reinforce symptoms. Alongside therapy, consider medication under the guidance of a psychiatrist or physician. While being aware of the medication can ERP ineffective by dulling anxiety responses. So it's also essential to monitor safety behaviors or subtle compulsions done to take the edge of exposures, since these interference with the true learning. So ERP to work, the brain must stay highly anxious until the anxiety decreases naturally. So meaning relaxation techniques or shortcut can reduce effectiveness. So the process requires being fully challenged for long-term change to occur. Exposure in ERP involves these deliberate confrontation of the thoughts, the images, or situation that typically trigger the emotions such as fear, distress, obsessions, and ritualistic behaviors. Instead of avoiding these triggers, the client face them directly, whether it's touching the surface they believe is contaminated, and imagining a feared scenario, or allowing intrusive thoughts to surface without pushing them away. Now, the goal is to teach the brain that, again, anxiety and discomfort can be tolerated without resorting to compulsion, and that feared outcomes are unlikely to occur. So, this gradual structured practice reduces the intensity of anxiety over time and helps break the OCD cycle. On response prevention, it is the second part of the ERP where you resist engaging in usual compulsions or reassurance seeking behaviors that temporarily relieve the stress. Now, the technique, such as deep breathing exercise, grounding exercise, or using distractions, can help manage the discomfort while staying committed to the performing of the ritual. By repeatedly experiencing triggers without compulsions, you refrain your brain to no longer associate obsession with the need for relief. So over time, this process makes anxiety fade naturally. So allowing you to face triggers and with greater confidence and freedom from OCD's grip. Okay. So finding obsessions begins with the paying attention, with the intrusive thoughts, images. Now there are resources out there to maintain or to identify some of the obsessions, no, the likely contribute to the compulsions. So these are the unwanted feelings or that you cannot control and may revolve around themes such as contamination, harm, morality, or symmetry. Unlike ordinary worries, obsessions are persistent and irrational, yet they create intense anxiety that feels difficult to ignore. So a helpful way to identify them is by noticing patterns and what consistently triggers your discomfort or what thoughts you try hardest to push away. So it can also be helpful or useful to track when anxiety spikes and what mental content accompanies, since obsessions often appear just before the urge to perform compulsion. Writing down these recurring thoughts without judgment helps the client clear and easier to work with in therapy. So by naming and recognizing obsessions for what they are, just thoughts rather than truths, you can begin to separate yourself from these or them, creating the foundation for exposure exercises and long-term recovery. So these are some of the list of identification of compulsions and matching the obsessions with the compulsions. So in this table, for example, you will see and identify the obsessions which lead to a specific compulsion and then narrow down and connect them if you are unable to identify connection. And that's okay. So you have to create that safe space for yourself while maintaining relaxation as well, no? With identifying these activities. Okay, so these are some of the tools. As mentioned, we can rank obsessions and compulsions. These are the steps. Number one, begin with the least distressing obsession. Expose yourself to situations that usually trigger obsession compulsion. It may lead to gradually move your way down to a more bothersome obsessions and compulsion, and then repeatedly exposing to these um, compulsions or exposing yourself with these activities. There are some scripts as well for the acceptance of the OCD. Okay, so again, these learning session is more of the introduction of the OCD and ERP, how it applies in the therapeutic and how it applies with therapeutic sessions or activities. Okay, so this is the ERP symptom monitoring. So the worksheet on different identification of date and time, the situation, the thoughts, the stressing level, compulsive activities, time spent, and what made it stop doing the compulsive activity. So this is how, for example, it is accomplished. Okay, so there are different goals, and then the worksheet of identifying what step no is in the hierarchy no and rating the distress anxiety, so the goal is to maintain it to 50. Okay, identifying as well which is the most difficult and the easiest ones. Okay, So by maintaining these exercises, we tend to control the distressing event or the anxiety level to 50 or even lesser. Once again, thank you so much for listening to this learning session, and hopefully to see you the next time.